The stroke patient was deteriorating rapidly, and the paramedic was panicking about which hospital to choose. The ambulance driver glanced in the rearview mirror and made a decision that violated protocol but saved a life. That's when everyone realized their simple driver understood neurology better than most doctors. Welcome to Interesting Human Stories. Before we dive into this gripping tale of hidden expertise and life-saving decisions, tell me in the comments what city you're watching from today. And if you believe that heroes often hide in the most unexpected places, hit that subscribe button. These stories remind us that greatness doesn't always announce itself. The morning shift at City General Emergency Medical Services began at 6 a.m. sharp, with ambulance crews checking equipment, reviewing overnight calls, and preparing for another day of responding to medical emergencies across downtown Chicago. The garage housed 12 ambulances in various states of readiness, their red and white paint schemes dulled by countless miles of urban rescue runs. Michael Santos had been driving Ambulance 47 for 3 years, partnered with a rotating crew of paramedics who appreciated his steady driving and quiet professionalism. At 54, he was older than most ambulance drivers, with graying temples and the calm demeanor of someone who'd seen enough emergencies to remain unruffled by chaos. His colleagues knew him as reliable but unremarkable. He arrived on time, maintained his vehicle meticulously, and navigated Chicago's traffic with the skill of someone who'd memorized every street, alley, and shortcut in the city. He rarely offered opinions about medical procedures, deferred to paramedic judgment on patient care, and maintained the professional distance expected of someone whose job was transportation rather than treatment. What they didn't know was that Dr. Michael Santos had spent 20 years as one of the country's leading neurosurgeons, with a specialty in complex brain trauma cases that had made him a legend at Northwestern Memorial Hospital. His hands, now gripping a steering wheel, had once performed microsurgery on blood vessels thinner than human hair. His mind, now focused on traffic patterns and response times, had once made split-second decisions that determined whether patients lived or died on the operating table. Michael's transformation from renowned neurosurgeon to ambulance driver hadn't been a choice. It had been a necessity imposed by circumstances beyond his control. The end of his medical career had come suddenly, devastatingly, and with a finality that had forced him to rebuild his entire identity. The incident had occurred during what should have been a routine surgery, a craniotomy to remove a benign tumor from a 34-year-old teacher's frontal lobe. Michael had performed hundreds of similar operations, with a success rate that placed him among the top neurosurgeons in the Midwest. But during this particular procedure, something had gone catastrophically wrong. The patient had experienced an unexpected hemorrhage, bleeding that required immediate intervention to prevent fatal brain damage. Michael had responded with the expertise that had made him famous, but despite his best efforts, the patient had suffered complications that left her with permanent cognitive impairment. The malpractice lawsuit that followed had been devastating, not because Michael had made any technical errors, but because the patient's family had argued that he should have recognized risk factors that weren't apparent in the pre-surgical evaluations. The case had dragged on for 2 years, consuming Michael's savings, destroying his reputation, and ultimately resulting in a settlement that had bankrupted him financially and emotionally. More damaging than the financial cost had been the loss of confidence that had followed. Michael had begun second-guessing his surgical decisions, hesitating at moments when decisive action was required. His colleagues had noticed the change, and hospital administrators had quietly suggested that he might benefit from a leave of absence. The leave had stretched into months, then years, as Michael had struggled with depression, anxiety, and the crushing weight of knowing that his life's work saving lives through neurosurgery was no longer possible. The job with City General EMS had been a lifeline when Michael had needed it most. His medical background, even with the cloud of the malpractice case, had made him an attractive candidate for emergency medical services. He'd been hired as an ambulance driver, a position that allowed him to work in healthcare without the liability risks of patient treatment. The work had been humbling initially. After 2 decades of being addressed as Dr. Santos and consulted on life-and-death medical decisions, Michael had become simply Mike, responsible for getting paramedics and patients to the hospital as quickly and safely as possible. But gradually, he'd found unexpected satisfaction in the role. Emergency medical services required different skills than neurosurgery, but they were skills that Michael had possessed all along: the ability to remain calm under pressure, to think quickly in crisis situations, and to work as part of a team focused on saving lives. His medical knowledge, while officially irrelevant to his driving duties, had proven invaluable in understanding the urgency of different calls. Michael could read EKG strips, interpret vital signs, and assess patient conditions with accuracy that helped him prioritize routes and communicate with hospital emergency departments. Most importantly, the work had allowed Michael to serve patients again, even if his role was different from what it had once been. Every successful transport, every life saved because he'd gotten the patient to appropriate care in time, had been a small step toward healing the psychological wounds left by the end of his surgical career. Working with paramedics had required Michael to navigate the complex dynamics of emergency medical teams. His partners changed regularly as schedules shifted and personnel moved between units, but most had been young, energetic professionals who approached emergency medicine with the confidence that came from extensive training and practical experience. Michael had learned to appreciate their expertise while keeping his own medical background largely hidden. He discovered that mentioning his surgical experience often created more problems than it solved. Some paramedics became defensive about their treatment decisions, while others wanted to debate medical procedures in ways that weren't appropriate for his current role. His most frequent partner was Lisa Rodriguez, a 29-year-old paramedic with 6 years of EMS experience and a reputation for calm competence in high-stress situations. Lisa had initially been skeptical of working with an older driver who seemed overqualified for his position, but she'd gradually come to appreciate Michael's reliability and his intuitive understanding of which calls required immediate transport versus extended field treatment. "Mike's got good instincts," Lisa had told other paramedics. "He seems to know when we need to load and go versus when we have time for comprehensive assessment. It's like he understands the medicine even though he's not supposed to." Michael had been careful not to overstep his boundaries, but he'd occasionally offered observations that had proven helpful. When Lisa had been confused by a patient's symptoms, Michael might suggest additional assessment questions. When transport decisions were unclear, he'd quietly recommend hospitals with specific specialties that matched the patient's needs. The call that changed everything had come on a Tuesday morning in October. A 67-year-old man experiencing apparent stroke symptoms at a downtown office building. The initial dispatch information had been routine. Possible CVA, conscious but altered, paramedic response requested. Michael and Lisa had responded code 3, emergency lights and siren, arriving at the scene within 8 minutes of the call. They'd found the patient Harold Chen sitting in his office chair, surrounded by concerned colleagues who'd called 911 when he'd suddenly begun slurring his words and complaining of dizziness. Lisa had performed her initial assessment efficiently, checking vital signs, blood glucose, and neurological function using standard stroke evaluation protocols. The patient's symptoms had been consistent with cerebrovascular accident, weakness on the right side, facial drooping, and speech difficulties that suggested left hemisphere involvement. "Looks like a stroke," Lisa had radioed to dispatch. "We'll need destination hospital for stroke protocol." This was where the complexity had begun. Chicago had multiple hospitals capable of treating stroke patients, but they weren't all equal in their capabilities. Some had comprehensive stroke centers with neurologists available 24/7, while others had basic emergency departments that would need to transfer critical cases to higher levels of care. Standard protocol required paramedics to transport to the nearest appropriate facility, which in this case would have been Mercy General, a community hospital 15 minutes away. But as Michael had listened to Lisa's assessment and observed the patient's condition, he'd realized that this wasn't a standard stroke case. While Lisa had been preparing the patient for transport, Michael had been processing details that his trained medical mind couldn't ignore. The patient's symptoms weren't progressing in the typical pattern of most strokes. The weakness was inconsistent, the speech problems were fluctuating, and there were subtle neurological signs that suggested something more complex than a simple cerebrovascular accident. Based on his 20 years of neurosurgical experience, Michael had suspected that Harold Chen wasn't experiencing a typical stroke, but rather a hemorrhagic event, possibly a subarachnoid hemorrhage or intracerebral bleeding that would require immediate neurosurgical intervention. The distinction was critical. Ischemic strokes caused by blocked blood vessels were treated with clot-busting medications and supportive care. Hemorrhagic strokes caused by bleeding in the brain required completely different treatment and often needed emergency surgery to prevent fatal brain herniation. Mercy General, the nearest hospital, had excellent emergency medicine capabilities but lacked a neurosurgical program. If Michael's assessment was correct, transporting there would mean an additional transfer to Northwestern Memorial or another comprehensive center, time that could be fatal for a patient with active brain bleeding.
as Lisa had continued her assessment. Preparing to load the patient for transport to Mercy General, Michael had made a decision that would violate EMS protocols but potentially save a life. "Lisa," he'd said quietly, "I think we should go to Northwestern instead." Lisa had looked up from her patient care, surprised. Protocol was clear, and Northwestern Memorial was 25 minutes away in downtown traffic, significantly longer than the transport to Mercy General. "Mike, Mercy's closer and they're stroke-capable. We need to follow protocol." Michael had glanced at the patient again, noting subtle changes in consciousness and pupil reactivity that confirmed his suspicions. "This isn't a standard stroke. Look at his pupils. They're becoming unequal. That suggests increased intracranial pressure, probably from bleeding." Lisa had been trained to rely on protocols and medical control physician guidance for complex decisions, but she'd also learned to trust her experienced partner's judgment. She'd taken another look at Harold Chen, noting the pupillary changes that Michael had identified. "Are you sure about this?" she'd asked. "If you're wrong, we're adding 10 minutes to transport time for a stroke patient." "If I'm right," Michael had replied, "we're getting him to neurosurgeons who can operate immediately instead of doctors who'll have to transfer him anyway." Lisa had made the call to dispatch, requesting permission to divert to Northwestern Memorial due to evolving neurological symptoms suggesting surgical intervention. The dispatcher had been reluctant to approve the protocol deviation, but Lisa's clear description of the patient's changing condition had eventually secured approval. During the transport to Northwestern, Michael had driven with the controlled urgency that had characterized his surgical career, fast enough to minimize time to definitive care, but smooth enough to avoid jarring a patient with potential brain bleeding. He'd maintained radio contact with the receiving hospital, providing detailed information about the patient's presentation and suspected diagnosis. More importantly, he'd continued to monitor Harold Chen's condition through observation in the rearview mirror, watching for signs of deterioration that would require immediate stopping for advanced airway management. Northwestern Memorial's emergency department had been prepared for their arrival, with a stroke team assembled and a neurosurgeon on standby based on the radio report Michael had provided. Harold Chen had been rushed directly to CT scanning, where the diagnosis had been confirmed within minutes. Subarachnoid hemorrhage with signs of active bleeding and early hydrocephalus, exactly what Michael had suspected based on his field assessment. The patient had been taken immediately to the operating room, where neurosurgeons had performed an emergency craniotomy to control the bleeding and relieve pressure on the brain. Dr. Patricia Williams, the attending neurosurgeon, had approached Michael and Lisa in the emergency department after the initial surgery was completed. "Your field diagnosis was remarkable," she'd told Lisa. "Most paramedics wouldn't have recognized the signs of SAH versus ischemic stroke." Lisa had glanced at Michael, then back at Dr. Williams. "Actually, it was our driver who identified the bleeding. He recommended the transport to Northwestern." Dr. Williams had looked at Michael with increased interest. "That's impressive diagnostic ability for an ambulance driver. Do you have medical training?" Michael had hesitated, knowing that his answer would inevitably lead to questions he wasn't sure he was ready to answer. "Some," he'd said simply. But Dr. Williams had persisted. "What kind of medical training? The field assessment you made requires pretty sophisticated neurological knowledge." Over the following days, word had spread through Northwestern Memorial's emergency department about the ambulance driver who'd correctly diagnosed subarachnoid hemorrhage in the field. Harold Chen had made a full recovery, crediting the quick transport to appropriate neurosurgical care with saving his life. Dr. Williams had made discreet inquiries about Michael's background, eventually learning through mutual contacts that he'd once been a colleague. Dr. Michael Santos, the neurosurgeon who'd left Northwestern years earlier under difficult circumstances. Their conversation had taken place in the hospital cafeteria, away from the emergency department where Michael had become something of a celebrity among the medical staff. "I wondered if it might be you," Dr. Williams had said. "The diagnostic skills, the knowledge of neurosurgical capabilities, it all made sense once I realized who you were." Michael had nodded, unsure how to explain his transformation from neurosurgeon to ambulance driver. "I needed a change after everything that happened. The malpractice case, I remember. But Michael, what happened with that patient wasn't your fault. Complications happen, even to the best surgeons." Michael had appreciated the support, but the emotional scars from the end of his surgical career ran deeper than professional recognition could heal. "I lost confidence in my abilities. Couldn't trust my surgical judgment anymore. But your diagnostic abilities are clearly intact. You saved Harold Chen's life with that field assessment."
Dr. Williams had made Michael an offer that would have seemed impossible just weeks earlier. Northwestern Memorial was expanding its emergency neurology program, developing protocols for field identification of complex neurological emergencies. They needed someone with advanced neurosurgical knowledge who could work with EMS teams to improve pre-hospital diagnosis and transport decisions. The position would be part of our emergency department. Dr. Williams had explained. You'd work with paramedics, provide consultation on complex cases, and help develop training programs for field recognition of neurosurgical emergencies. The offer had been tempting, but Michael had been reluctant to return to medicine in any formal capacity. The wounds from his malpractice experience were still too fresh, the fear of making mistakes too overwhelming. I appreciate the offer, Patricia, but I'm not sure I'm ready to take responsibility for patient care again. You wouldn't be providing direct patient care. You'd be a consultant, an educator, someone who helps other medical professionals make better decisions. It's different from surgery, but it's still serving patients. Michael had asked for time to consider the offer, but privately he'd been struggling with the decision. Part of him longed to return to meaningful medical work, while another part was terrified of the possibility of making mistakes that could harm patients. After 2 weeks of consideration, Michael had accepted a modified version of Dr. Williams' offer. Rather than joining Northwestern's staff directly, he'd agreed to work as a consultant for City General EMS, developing protocols for neurological emergency recognition and providing training for paramedics on complex case identification. The arrangement had allowed Michael to remain in his ambulance driver position while gradually taking on additional responsibilities that utilized his medical expertise. He'd begun conducting monthly training sessions for EMS crews, teaching advanced assessment techniques for neurological emergencies. His reputation within the EMS community had grown quickly. Paramedics had begun requesting Michael as their driver, knowing that his presence provided an additional layer of medical expertise that could be invaluable during complex cases. Lisa Rodriguez had become one of his strongest advocates, crediting their partnership with improving her own diagnostic abilities. "Working with Mike has made me a better paramedic," she'd told supervisors. "He sees things that I miss, asks questions that help me think more systematically about patient presentation." Michael had also begun developing relationships with receiving hospitals, serving as an informal liaison between field personnel and emergency department staff. His surgical background had given him credibility with physicians who might otherwise dismiss paramedic assessments of complex cases. 6 months after the Harold Chen case, Michael had found a balance between his past as a neurosurgeon and his present as an emergency medical services professional. He continued to drive Ambulance 47, but now his role extended beyond transportation to include field consultation, protocol development, and medical education. The work had been healing in ways that Michael hadn't expected. Instead of the isolation and pressure of the operating room, he was part of a team focused on collaborative patient care. Instead of the burden of making life and death decisions alone, he was helping others develop the skills to make those decisions appropriately. Harold Chen had recovered completely from his subarachnoid hemorrhage and had sent a letter to City General EMS thanking the crew who'd saved his life. In it, he'd written, "I don't know the name of the ambulance driver who recognized that I needed specialized care, but I want him to know that his expertise gave me back my life." Michael had kept the letter in his uniform pocket, a reminder that medical service could take many forms and that healing, both for patients and for healers, happened in unexpected ways. Dr. Michael Santos still drives Ambulance 47 for City General EMS, but his role has evolved far beyond simple transportation. He's become the EMS system's unofficial neurological consultant, the paramedic educator who helps field personnel recognize complex emergencies, and the bridge between pre-hospital care and definitive treatment. His story has spread throughout Chicago's medical community, inspiring discussions about how experienced physicians can continue serving patients even when traditional practice is no longer possible. Several other doctors facing similar career transitions have reached out to Michael for advice about alternative ways to use their medical knowledge. Northwestern Memorial has formalized their relationship with Michael, creating a position that allows him to maintain his EMS role while contributing to their emergency neurology program. He reviews complex cases, develops training materials, and occasionally provides consultation on unusual neurological presentations. Most importantly, Michael has found peace with his past while embracing a future that allows him to serve patients in ways he never imagined. The surgeon's hands that once held scalpels now grip a steering wheel, but they're still guided by a mind dedicated to saving lives. Harold Chen wasn't the last patient whose life was saved by Michael's ability to recognize neurological emergencies in the field.
There have been dozens of others: stroke patients transported to appropriate facilities, trauma victims identified as needing neurosurgical evaluation, cases where subtle diagnostic insights made the difference between recovery and permanent disability. Michael Santos may no longer perform brain surgery, but he continues to save lives. He's proven that medical expertise doesn't disappear when careers change, and that the desire to heal can find new expressions even after devastating setbacks. From the operating rooms of Northwestern Memorial to the streets of Chicago, Michael's journey shows us that healing comes in many forms, and sometimes the most important surgery is the one performed on our own broken dreams, carefully reconstructed into new purposes we never knew we needed. So now I ask you, have you ever encountered unexpected medical expertise in someone whose job seemed unrelated to healthcare, someone whose careful attention suggested knowledge beyond their current role? Someone who chose to serve others despite personal setbacks that could have broken their spirit? Share their story in the comments. Because here at Interesting Human Stories, we believe that the desire to heal doesn't disappear when circumstances change. It simply finds new ways to express itself. The most powerful medicine is often delivered not in operating rooms, but in moments of quiet expertise that save lives when no one is watching. If this story moved you, subscribe and share it. Help us honor the healers who continue serving long after their original paths have ended, who find new ways to use their gifts in service of others. We'll see you in the next story. Until then, remember, the person driving your ambulance, helping at your local clinic, or working quietly in healthcare support roles might be carrying more knowledge and experience than you could ever imagine.